Hello, and welcome to this episode of Roll Call, TTSH Nursing's very own podcast, brought to you by the Centre for Asian Nursing Studies. I'm Kim, and I will be your host for today's episode. So today's episode is on NCID, our National Centre for Infectious Diseases, and it's a 330-bed purpose-built facility designed to strengthen Singapore's capabilities in infectious disease management and prevention. It provides in- and outpatient clinical services and houses the nation's only high-level isolation unit and surge capacity for outbreak responses. On top of its clinical services, NCID also houses research, training and education and community engagement under one overarching structure. Today, I have two of my colleagues from NCID joining us on Roll Call. Give it up for Assistant Nurse Clinician Sarah and Nurse Clinician Nathan. Hello!
Hi!
Okay, so I've met Sarah and Nathan once before today's filming session and found out that Sarah has actually been working here since the year I was born. And I think that goes to show how many years of memories and experiences my guests here today have. So could you guys share with us more about yourselves and your background here at TTSH? Anyone can start first.
Hi, I'm Sarah. Okay, I start first, okay? Sarah from Clinic J. I started nursing, like what Kim said, 1996. That was the year I was born. I was like shocked. My interest didn't, didn't start from beginning, okay? So it is through years of experience. Then gradually from the point when I was being bonded after I signed the contract with TTSH in year 2, then many of my colleagues, many of my schoolmates actually was kind of scared to come over to CDC to work at that time. And they find that the place is so-called unsafe. To me, right, I just find that the most dangerous place is the safest place. So through these years, right, I've learned a lot of nursing care for infectious disease such as the dengue, malaria, chickenpox, herpes zoster, measles, rubella, Nipah virus, Hendra disease, and SARS. It's my time.
Okay, so my name is Nathan. I'm not that old. I started nursing around the year 2012. So at that time, I joined Tan Tock Seng and I was in a neurosurgery step-down unit. So actually, why infectious diseases? Because we are guys, right? And we cannot go for our op and gynae posting. And so we will all be posted to CDC to do that 2-week posting. And at that time, I had a CI there who made things very interesting in the clinic. Of course, I tell us a lot of story, teach us a lot of things. She happens to be my colleague now, and that happened around the year 28. So that was when I had a very good experience in CDC and infectious disease nursing, and that's when I wanted to come back to Tan Tock Seng and join infectious diseases, which is why I'm here now lah. So from neuro step down in 2012, it took me a few years. I went and did my medical surgical studies, and then around 2018, I went to CDC to join them.
Add on, CDC time, it wasn't a hot cake place.
Why?
They kind of find the place very eerie and scary because a lot of infectious disease are there. At that time, it was the leprosy. Everyone was scared.
So before we talk about NCID, we need to honor what came before. And I think you guys have heard us use the term CDC the past few minutes, right? So what is CDC? CDC is actually our Communicable Disease Center or centers. There was CDC 1 and CDC 2. And one fun fact is that the three of us have worked in CDC before, I think during different points in time, because I don't think our paths crossed, right?
No.
When we were in CDC. So how was it like working at CDC for the two of you? Because I think I was there closer to the tail end of CDC before NCID was built. How was it like for the two of you?
Well, the place is very secluded, okay? To find food is an issue. There's a lot of nature around. My patients are very nostalgic about the wildlife in CDC, big trees and fruit trees as well we have. So, in terms of my clinic, right, we have issues like sending labs to do the analysis. we have to get a porter.
Yeah, very far.
Either they cycle or we have to call the ambulance.
cycle.
Yeah. Or we tag on some other wards who are engaging with the ambulance. And then we hitch on it to get our porter to send the specimen to the laboratory. Yeah. And also if we have patients who are on chest x-ray,
Yeah.
who need to be done, we need to send them to TBCU to do the chest x-ray. And then not only that, not just the patient in the ambulance, but we also need manpower to accompany the patient. Yeah.
My experiences is also like Kimberly's, not really towards the tail end, but still the end lah. And yes, like what Sarah said, labs had to be sent to a laboratory in Tan Tock Seng, and then if you have to do an X-ray, you also have to bring the patient all the way to TTSH. I mean, facilities there were limited. They were because it's an older building. It was also planned for times that were different lah. So, which is why the transition to NCID was also needed, because now that we have over the years we realized that we will probably need ICU capabilities, we will need outbreak capabilities, we will probably need our own lab, own pharmacy, own radiology department. Which is why I would say the move to NCID was also very needed for this day and age. I mean, in some way, we can also say that, the turnaround time is faster, patient experience is also better lah, because things get done more efficiently.
I would like to add on something. Not forgetting that and CDC doesn't have a very good facility for negative pressure.
Correct. Before that, right, let's move on to present day NCID. And I think a very common question that we get, not just from nurses but also general public, is what is the difference between NCID and our main Tan Tock Seng building or wards?
Like earlier on, I mentioned negative pressure.
Oh yes. What negative pressure? Maybe you can explain a bit.
The negative pressure, actually, we will screen patient at a pre-screening to check whether the patient has any other travel history, any like respiratory symptoms and all that. Then we will segregate them and see in a special negative pressure room lah, so to speak. And the negative pressure room, we also split into 2 zones lah, okay? Then the doctor will come in and see them wearing full PPE. So it's relatively safe for all healthcare workers to work in that condition. And it's air conditioned. And it's not like those days when we were in CDC wearing the full PPE, we were all sweating over. And we also have the screening center, not to forget that. If there's an outbreak, we are ready to fight for the next wave.
Hopefully not, please.
Hopefully no wave.
No.
Okay.
I think inpatient-wise, you would realize that most of our rooms, except for a few wards, are single-bedded isolation facilities.
Okay.
There are a few wards that have 2 beds in one room,
but
they are also all negative pressure. So every room in NCID inpatient wards are negative pressured, with a pressure gauge to monitor the negative pressure and all that. So it's unlike CDC where not all the rooms were negative pressure. We did have a small facility that was later built in CDC 1 that held 5 beds of negative pressure rooms. But in NCID, what's different and what's unique is that every room is negative pressured actually.
I heard from patient, is it true that patient has a multi-million-dollar view?
Oh, the views. I've sent a patient to NCID before, right? And I was like, oh my gosh, the view here looks like hotel. I feel like I'm in a hotel.
What patients can get to see if they are in certain wards is the view of the Marina Bay Sands lower up.
Really?
Yes.
Wow.
So especially, let's say New Year's and National Day, right? If they want to see fireworks, get admitted in that certain beds. You can see the fireworks at full view.
Oh, wow. Oh, I didn't know that.
And it's at a level where, if I'm standing, right, it's just right in front of me. Yeah.
Oh, okay, but hopefully not. Hopefully you won't be admitted during the period to see the fireworks,
Please don't come here just to see fireworks.
Okay, so during our meeting, right, you guys also reminisce about how nursing has changed so much over the years, you know, since you've been here for quite a while. Could you paint for me a picture about how healthcare, maybe especially in the realm of infectious diseases, how much has it changed over the years?
Oh, we have the RTLS tag. Okay, the RTLS tag stands for real-time location system. Okay, so we will track the patient when they come into my clinic and inpatient as well. So that if there's a, you know, sometimes pre-screen we may miss out certain things. The patient didn't tell us the symptoms or too scared to inform us, then we can track. The epidemiology will take down who are the patient, who are the patient or healthcare workers in contact with the particular patients do contact tracing.
This RTLS tag is a real-time location system.
Yep.
Actually, what it does, and I think Main Block is also adopting it, it is number one, we can also use this facility to contact trace. So let's say, people come day in and day out, come into the hospital, and suddenly there's infection or something. This tag helps in contact tracing and like narrowing down on any possible contacts and all that. So that is one. Number two is this tag is also assists in lessening the nurses' workload, and nurses and doctors' workload, by helping to monitor for any unauthorized departures from the hospital. Yeah. So in some way, it's leveraging on technology to lighten the work, the load of the staff. So it helps in contact tracing, it helps in monitoring unauthorized departures and all that. Yeah.
Okay.
Other things, how infectious diseases nursing has evolved is whenever we talk about nursing, we always think, oh, it's just clinical, it's just administer treatment. But nowadays, nursing is just not clinical, but there are also research. The clinical aspect is a huge aspect, but there's also research, there's also education, trainings, and informatics that comes in. So NCID is very huge on sustainability. So we have a colleague of mine who spearheads sustainability projects in NCID, how we can reduce waste, how we can reduce carbon emission. We also have this department called NCID Think, which is very research orientated, also spearheaded by one of my very close colleagues. So we look at how we can incorporate evidence-based practice into our daily nursing care. We also look at how we can educate our nurses to look at research evidence and kind of apply it to their care. Then we also have like various trainings, like we send our staff for outbreak drills, vaccination training, all this, although the outbreak doesn't happen, it's also to be prepared in case something happens. So at least, when something happens, we don't just go in like doing like a blind shot. We are prepared. Then there's also a lot of informatics. We are very hugely trying to depend on technology now. So we have like our iPad at bedside. Everything is electronic now. Medications are served through an electronic system, like even in Tan Tock Seng. So we play a huge, we leverage a lot on technology now, to simply put it.
My clinic also does some other things like nurse lab program for our patient. So three of the vaccines that we are screening for is influenza, pneumococcal polysaccharide 23 vaccine, and pneumococcal conjugate 13. So these are MediSafe claimable. So our nurses will screen them. This is one of the clinic initials that we have done so far.
Understand.
And also we also have journal club every Friday for nurses and PSA to upskill and also to learn.
Oh, PSAs are involved in journal club also?
Yes, we were together. We would get them to involve with them. And daily we have roll call as well. We also do some mindfulness once in a month, like 15 minutes of deep breathing exercises. So the clinic is not just clinic patients come and visit, but we do have a lot of clinical skills for our nurses as well.
You know, a lot of our nurses now, both in the inpatient and outpatient setting, right? They are all involved in very national level clinical programs also. You know, so at least you know, when we talk about national level programs, it's always, you know, everyone thinks it's very medical directed, but we also have a nursing voice in it.
Yeah. Okay, I just wanted to kepo, right, and ask you guys, because just now you mentioned about SARS as well. How was going through SARS versus going through COVID like? Was it very, very different, the experience?
My SARS time lasted half a year.
Oh, SARS?
Yes.
I cannot remember, I was like in primary school, I think.
Okay, the difference between SARS and COVID SARS time, right? We do not have any post-exposure prophylaxis for patients or whoever get exposed. Okay, so COVID different, right? All of us have post-exposure prophylaxis, like giving the injection, correct? Yeah. So that's the difference. So we do see those patients come back after SARS recovery. Yeah.
My SARS experience, I mean, free school holiday, man. I was 13.
Sorry, really?
I was really 13 at that age. So it was woohoo.
Yeah. I think Sarah is the only one that was working already.
But COVID, I guess what happened was that we probably learned a lot from SARS, and that's why they also felt that probably we need a building like NCID, and we were more prepared. So I felt that it was dealt with differently. When we admitted patients, it was very targeted. You know, not everyone was admitted. Over the time, even no criteria for admission and all that were reviewed, because you know, whenever a disease happens, we learn new things, and then through that we make better decisions. I think COVID, we kind of did manage it well. And of course there was more research for COVID. There was also more availability of drugs. Like our monoclonals and all that.
So speaking of COVID, right, what would happen if, let's say, another outbreak was announced right now?
Oh, don't worry. We are prepared.
I
Don't want. We are
Hopefully
prepared.
not, yeah. But what if? What if?
Okay.
I think we are very covered lah, because after COVID, we also learn more things lah. So I think now we are even more prepared. Like should an outbreak happen.
So for clinic-wise, right, we have this core tree system. So we have 4 groups split into among equally the nurses and the PSA. And how it does is my RO, the manager, will just give us the first leader a call, and then subsequently we have to call the next person. She will just tell us what is the background in S-bar. After that, we'll call the next person in line. Then the last person need to revert back to the manager again, what you have been delivered. And we need to come down to the clinic to set it up within 4 hours. So we are well prepared.
For our inpatient side, what I would say is that there is like established protocols and workflows for when an outbreak happens. So I think this protocol is very readily available also in our system. So let's say an outbreak happens and someone calls us, we already know what to do. Like we have to do step 1 to step 10, and everything will be ready.
What do you love about working at NCID?
Patient satisfaction, because my day in, day out is those patients who come regularly to my clinic, and I see them like maybe half a year once or once a year. So it's like not new patients lah. So kind of a lot of patients who know us, then they give us a lot of warmth as well, and then more achievable. What do you call that? We engage and bond with the patient.
Because you really journey with them over a long period of time, right?
I think working at NCID, because it is a very like kampong and smoke, very niche department, right? Everyone kind of knows each other. So like I said earlier, when I said it was easier to go for cross-department deployments, everyone knows each other to a point where you can see various wards, different staff from different wards, all maybe going out together after work, going overseas and all that. Patient-wise, what we do have is that because some of our patients do come in on and off to our facility, and it's sometimes easier to get them to adhere to treatment and do certain things because they know you, then they are more friendly. Then like, hey, my friend tell me, then I will do lah. Rather than if it's a new patient, someone you suddenly see and then you tell them to do something, they'll be like, why must I do? So I guess the rapport with patients in our department is a bit better. I feel it's very good lah.
So thank you so much, Nathan and Sarah, for joining me today on this podcast. It was very nice to hear about all your experiences, not just at NCID but at CDC as well. So sadly, that brings us to the end of this episode of Roll Call. Thank you so much for joining in once again. You can also check out this podcast on Spotify at Nurses of TTSH, and you can find us on Instagram and TikTok at Nurses of TTSH as well. So we'll see you guys in the next Roll Call. Bye!